Are you agree that can you examination? Okay, I understand. Okay, I can take maybe the.
Maybe we'll
yeah. So up. You should just give me 1 second. Okay. Oops. Okay, I tried something. Oops. Okay, partager. I will try. Maybe I want to be sure. I don't know what you can see.
We don't see it, the full mood.
Okay, so new thing.
When you
like it.
Yeah, when you click on share screen, maybe we need to. Yeah, exactly now.
That's fine.
Yeah, this is perfect.
Okay. So I just want to.
Dr. Shuaib.
Okay, so.
We want to introduce you, Prof, first.
Okay, sure. Sorry.
Thank you, Dr. Abdullah. And it's a pleasure to be here today. We are really, truly honored to have you, Professor, with us, Professor Solasol. He's an accomplished medical professional and researcher at the University of Montpellier in France. Professor Solasol begins his journey with medicine at University of Montpellier, where he acquired his Doctor of Medicine degree in 2000, and then he obtained his PhD in cellular biology in 2003. And in 2014, he was recognized as a professor of medicine. Currently, Professor Solasol heads the pathology department of biopathology at the University Hospital Montpellier. In research, Professor leads the team signaling of tumor invasion. And his research involved the use of high throughput genomic approaches, including next generation sequencing and mass spectrometry proteomics-based assays. He's not just a researcher. Professor is also deeply invested in educating the next generation of medical professionals. He teaches MD students, as well as students pursuing a master's degree in medical oncology and molecular biology at University of Montpellier. So today we have this unique opportunity to learn directly from Professor. And we are honored to have you, Prof. And we are really excited and eager to hear from you. And the virtual floor is yours.
Okay, thank you very much. First of all, I would like to thank you for your invitation to this HPB coffee session, and especially Fabrizio, so that I know very well. So you explained, I'm currently working at the Montpellier Hospital Center, University Center, in the pathology and oncobiology department, and I have a specific focus on the molecular section of the laboratory. So my presentation will talk today on the different molecular alterations and mainly oncodrivers that have been identified in digestive tumors in recent years. I will also talk or highlight my talk on the different screening technique that we developed and that are today able to identify this mutation. And more particularly, I will talk about the high throughput sequencing technique, which is known as NGS for next generation sequencing approaches. So for this presentation, I will follow the following outline. Firstly, I will provide a brief introduction of the emergence of targeted therapies in oncology and the development of what is known as precision medicine. Then I will present the different molecular alterations identified in the four most common digestive cancers, namely colorectal cancer, gastrointestinal tumors, intra and extrahepatic bile duct tumors, and also pancreatic tumors. Finally, I will conclude my presentation by discussing the most common techniques used to identify this molecular alteration. Oops. And explain the different process that we have implemented in our laboratory at Montpellier University Hospital for screening and determining these mutations. So on this timeline, you can see the parallel progression between our understanding of the mechanism underlying tumor development from an organ level perspective to a molecular level understanding and the evolution of therapeutic approaches. So as you can see, each steps in this progression has been associated with a change in patient management and the development of new therapeutic strategies. So in recent years, the advent of targeted therapy has considerably modified the field of in oncology. These treatments aim to specifically target the molecular alteration driving tumor growth, offering a more personalized and effective approaches. So this therapy have shown promising results for metastatic patient management in terms of improved outcomes and reducing the side effects. So the integration of the molecular profiling today and the identification of biomarkers has allowed to develop techniques that are appropriated to identify patients that could benefit from this treatment. So the idea is to give the good treatment to the good patient. So just as an example here, you can see, you can have an overview of all the molecules that have been approved by the FDA and are now available on cancer patient treatments. Most of them are linked to the development of new molecular tests that are called companion tests and are performed systematically prior any treatment using this targeted therapy, once again to be sure that the treatment could be effective for the patient. So what are the main alterations that have been identified in digestive carcinoma to date? First of all, among colorectal cancers, there are familial forms group in Lynch syndrome, which can be identified by determining the microsatellite instability status. So this reflects the functionality of the MMR system, which is responsible for DNA mismatch repair and correction of replication errors. So these errors are often observed in a repeated region of the DNA, which are called microsatellite or STR. So these tumors are highly immunogenic and have characteristics similar to lymphoid Crohn's disease. So in fact, the deficiency of the repair system can be detected using immunohistochemistry by assessing the expression level of different proteins associated with MMR status, or by examining abnormal repetition of the specific STR regions of the DNA. So as you can see on these flow charts, the identification of a familial form of colorectal cancer outside the conventional Amsterdam clinical criteria, and it should be performed so to identify this population. So in fact, this test can be also added with the detection of BRAF gene, which I will discuss later, and more specifically the V600E mutation. And you can also do the investigation of the methylation of the MLH1 promoter. So finally, if Lynch syndrome is suspected, based on these results, these molecular results, patient should be referred to oncogenetic consultation to have additional genetic testings. So the use of MSI testing is also widely employed in other indication for the management of colorectal cancer. It has been demonstrated that MSI status in stage 2 tumors with high risk of recurrence is a predictive marker for the efficacy of 5-FU chemotherapy. In addition, at the metastatic stage, it serves as an effective marker for directing patients towards a new treatment option, which is immunotherapy with anti-PD-1 agents. So this treatment has recently shown significant efficacy in a subgroup of patients, and a positive phase 3 study in 220 revealed that pembrolizumab immunotherapy outperformed frontline chemotherapy, leading to this drug to get the FDA approval. So yes, amongst the mutation identified in colorectal tumors, as you can see, there are several other mutations that primarily affect tyrosine kinase protein pathway, such as the MAP kinase pathway or the PI3 kinase pathway. The most frequently observed mutation is the mutation on the KRAS gene. So the RAS status is necessary today to determine the eligibility of patients for anti-EGFR target therapies. So specific mutation acting the KRAS on the NRAS isoforms, which are located at the codon 2, 3, or 4 of these genes, need to be tested. The presence of this mutation is associated with the resistance of the EGFR, cetuximab, and panitumumab treatment. So the prescription of this target therapy is limited only to patients without these mutations, and patients who are these patients are considered as wild-type RAS mutation patients. So in addition to the KRAS or NRAS mutation, you can see that there is also other mutation. For example, you have the mutation of the BRAF gene that is currently observed. So this mutation is known to have a poor prognostic value, and is usually associated with an overall survival of around 12 months. So there are common found in this mutation is usually found in right side colon tumors, in patients, in old patients, and in patients with lymph nodes and peritoneous metastasis. So, but BRAF is also interesting because since 219, this mutation has also been used as a treatment marker. So patients with BRAF V600E mutation can receive combination therapy of encorafenib and cetuximab as a second-line treatment. So this treatment combination has demonstrated its efficacy in a phase 3 Beacon study, leading to its approval by the FDA recently. So in addition, it's important to note that BRAF mutated colon tumors can also benefit from immunotherapy treatments. So to guide the treatment approach for this patient, it should be performed additional testing based on the MSI status. And in fact, when patients are MSI, they can be treated with this immunotherapy. Lastly, I would say that there is a wide range of genes with alterations that can guide patients towards targeted treatments. This can be achieved through DNA analysis or through RNA profiles determination. But most of these targeted therapies are currently focused on enrolling patients in clinical trials to evaluate their potential efficacy and safety, but they are not used in a routine field or in a routine aspect of patient treatment. So after discussing colorectal cancer, let's move to esophageal cancer. So one well-known marker in this context is the expression and the level of expression of HER2 in advanced form of the disease. So HER2 is used to select patients for treatment with trastuzumab in combination with chemotherapy and platinum-based chemotherapy as a first-line treatment. So HER2 expression is usually assessed by immunohistochemistry with a specific scoring system that differs from breast cancer. So in this scoring system, 3 crosses indicate positive results, 1 cross indicates negative results, and 2 crosses indicate the need of additional analyzing using fluorescence in situ hybridization fish. But in our laboratory, we perform this complementary analysis using only NGS approaches. So yes, we can complement the molecular analysis of these tumors with a scoring system called CPS for combined positive score. So the CPS represents the ratio of the number of cells expressing PD-L1, including so tumor cells and human cells. So the ratio of PD-L1 expression in these cells to the total number of cells. So as you can see here, I don't know if you have my arrow, but as you can see on this flow chart for inoperable or metastatic patients, this scoring help, if it's superior to 5, it help physician to guide patients to first-line treatment toward a specific chemotherapy or targeted therapy in specific clinical trials. A rapid word on gastrointestinal tumors, cysts, which you may know. And as you can see, these tumors are associated, with the presence of several hotspots in c-KIT and PDGFR genes. So these 2 mutations are very, very frequent, but are exclusive. If you have one, you don't have the other one usually. So cysts with mutation on these genes are preferentially treated with imatinib which is a tyrosine kinase inhibitor of the BCR-ABL oncodriver. So it's a kind of conventional treatment, and in some cases, rare cases, but some cases, you can also find other mutations such as BRAF V600E mutation or NTRK fusion or rearrangements, which can be specifically treated with specific treatments. One word concerning pancreatic cancer. So pancreatic cancer, in pancreatic cancer, you have a huge amount of different mutations that are represented here. So among these mutations, I have highlighted one mutation which is quite important, and it concerns mutation not on somatic, on tissue, but on germline cells. So in fact, in pancreatic cancer, you can have BCR1 or BCR2 gene alteration, molecular alteration. And when these genes are mutated, the tumors are particularly sensitive to platinum-based chemotherapy. And what is very important is that, in fact, recently it has been shown that this tumor can also be treated with specific treatment based on PARP inhibitors. These PARP inhibitors are alternative protein for the DNA repair pathway and the homologous recombination. So when you have a deficiency of this protein, you can treat patients with olaparib, for example. So this has been shown in the recent Polo study, which is a randomized study based on the presence of BRCA germline mutation in patients. So patients were randomized with platinum-based chemotherapy, placebo and olaparib treatment. So the assay was positive, and patient could have efficient benefits of the treatment with olaparib, as you can see on these Kaplan-Meier curves. So the BRCA positive patient in pancreatic cancer correspond to between 5 and 7% of patients. So today, all patients with pancreatic cancer, regardless their family potential germline history family, they should be treated or screened for BRCA mutation to potentially benefit for this very efficient treatment. There are still some rare molecular alterations that can be investigated in pancreatic cancer because they can also benefit from specific treatments. This mutation include, for example, BRAF, once again, and but also ALK fusion, ROS fusion, NTRK fusions that have, you can see, specific treatments and very efficient also treatments. What is important also to perform in this patient is to determine the MSI status, because patient can benefit from immunotherapy with very interesting results. Yes, and so lastly, I would talk about biliary tract cancer. Biliary tract cancer is a very good example to demonstrate how determining the molecular profile of the tumor has changed patient management recently. So you know that you have in this biliary tract cancer different anatomical type of cancer. You have intrahepatic cholangiocarcinoma, you have extrahepatic cholangiocarcinoma, and gallbladder tumors. So, for instance, it is well established now that in intrahepatic tumors, they most of the time carry mutation in EDH1 gene, and and they also have FGFR2 fusions, while extrahepatic tumors exhibit mainly HER2 or HER3 mutations. So as a result, today, patients with IDH1 mutation can be treated with ivosidenib, which is a IDH1 inhibitor. And for FGFR2, patient can be treated with several inhibitory molecules that have been evaluated in phase 2 clinical trial, but which are currently ongoing phase 3 studies with very significant response rates in these mutated patients. So to conclude on the existing link between molecular profiling of digestive cancer and prescription of this target therapy, I would say that in colorectal cancer, the following tests are needed and necessary: MSI, RAS-BRAF status, and the possibility of other markers for colorectal cancer. So in oesophageal tumors, it's primarily important to search for mutation in HER2 gene. In GIST, we can focus on c-KIT and PDFR genes. In pancreatic tumors, you should look for constitutional mutation in BRCA1 and 2 genes. And but you can also do it on somatic mutation if you want. I can explain you later if you want. And lastly, for biliary tract cancer, 3 markers should be investigated: HER1, FGFR2, and MSI. So the final part of my presentation, we focus on presenting the technical solutions that we have developed in our laboratory in recent years to carry out this molecular analysis. So it's important to note that we receive in our laboratory around 4,000 tissue samples per year for somatic analysis and around 1,500 blood samples for constitutional analysis, and so the detection of molecular alteration in familial cancer forms. So first, it's important to note that to guide clinicians and biologists in developing this test, there are different guidelines that are available. So in North America, we have the NCCN for National Comprehensive Cancer Network guidelines. And in Europe, we have the recommendation from the ESMO for European Society of Medical Oncology. So the ideas remain the same. In fact, molecular tests are assigned different level of performance based on their relevance in terms of clinical of overall survival, of progression-free survival for patients. So in fact, if I want to summarize, I would say that in our hospital and as well in France, everywhere in France, we follow the ESMO recommendations. And for level 1 molecular testing or molecular alteration, we have to search it in a clinical practice as a standard of care. And for level 2, 3, or 4, the tests can be performed, but to include patients in specific clinical trials. So class 1 in routine and class 2, 3, and 4 for clinical trials. That's what we do. So as you know, it's now possible to detect molecular alterations at the DNA or the RNA level using conventional techniques. As conventional technique, you have quantitative PCR, qPCR, single-strand Sanger sequencing. You can also perform FISH, but it's very sensitive and very good techniques. But the disadvantage of these approaches remains that they only allow the detection of a single mutation at one time. So in contrast, recently, around 10 years ago, NGS for next generation sequencing approaches has been developed, and they allow to identify hundreds of mutations in a single analysis. So you can provide this technique in routine laboratories. You can also perform a complete analysis, if you want, of the whole exome sequencing using this technique. And you can also analyze the total transcriptome of a sample, if you want, in a single run. The only thing that you cannot do using NGS approach in conventional laboratories is a whole genome sequencing. If you want to do whole genome sequencing, you have to send samples to specific national platform, which are called Sequoia in France, for example. So NGS is a very interesting and very relevant approach to identify what we call single nucleotide variation, SNV, including indels, for example. But you can also check for copy number variation, which means you can see the amplification of genes, the deletion of genes, which are involved in different tumoral processes. And on a RNA analysis aspect, you can, using NGS approach, identify SNV also, as well as for DNA analysis, but much interestingly, you can identify fusion genes. So here in Montpellier, in our lab, we do not develop no more FISH, qPCR, or single Sanger. Usually, excepting in specific cases, we only do all this process using NGS and several NGS approaches I will explain you right now. So one word concerning these NGS approaches. You have to know that there are two main types of techniques for performing NGS. Without going on details, I would say that the kind of technique you're going to use depend on the size you want to sequence. You have here an example of first generation sequencer that allow short read technology that are based on short read technology and that can allow short read sequencing. So it means you can amplify fragments of short pieces of around 150 or 250 passenger. And on the other hand, you have another kind of technology which is called last generation sequencer, which allow large read sequencing, so which can sequence longer fragments, which make them more suitable for reading extensive sequences, and which is quite interesting to detect structural variant anomalies. So today in our laboratory, we only use this first generation of sequencer because we need to identify hotspots or a limited number of alterations, and we're not really interested by identifying structural variant. So when you use this short amplification technology, here is presented the flow chart and then the process. So you can see that there is 4 main steps to consider. The first step involves extraction of DNA from tumor tissues, which is often done using automated extraction systems. The second step involves preparing samples to amplifying the DNA into millions of copies. This is called the construction of libraries. Subsequently, you are going to sequence these libraries into high throughput sequencer. and specific devices. And finally, you will analyze the data obtained from this sequencer and transform the file into files that can compare, in fact, the sequencing done on the patient and the reference sequencing that you can get. So very shortly also, but it's quite important. The technique it's important because it's technically important to differentiate what you can do using these NGS approaches. So you have two kind of way to perform libraries. You can do what we call amplicon sequencing or hybridation capture. It's not exactly the same. Amplicon technique involves amplifying specific region of interest. So this technique is sensitive, fast. It requires minimal amount of tissue and is largely used in hospital laboratories and notably in oncology laboratories. And you also have another kind of possibility. You can do what we call hybridization captures. So you're going to capture large amount of DNA, not short, but large amount of DNA. So using these approaches, it's very efficient to perform, for example, exome sequencing, or when you have a large number of content of gene that you want to detect. So you're going to perform this kind of approach. So you have different kind of technical approach depending on what you want to check. Here is just an overview of the process of NGS from the DNA extraction to the final results. So the time of the process is around 1 week, from the beginning to the end. And here are presented the 3 different devices that we have on our platform in Montpellier. So you can see that you have different sequencer. The difference between these sequencer are linked to the fact that one sequencer can perform short sequence and have a limited number of, you can run a limited number of patients on it, and more big is the sequencer, more important is your availability to analyze large number of genes or important high number of patients in one run. So depending on the flow that we have, we use one device or another device. One point concerns the fact that in oncology, it's completely different from heart disease. For example, we're working on tissue samples and we're working on a specific tissue. In fact, we're working on tissue that are formalin embedded, fixed and paraffin embedded, sorry. So the problem is that we're working on very small amount of tissue. Most of the time we receive biopsy specimens, and because, for example, in lung cancer, most of patients have not been treated by surgery because the diagnosis is done too late. So we have only specific and very short biopsies. This biopsy most of the time or can be necrosis, necrosis or fibrosis. So we have small amount of DNA, of tissue samples, and in fact DNA. Here is a representation of what we have in our lab. For example, you can see that more than 20% of our sample have only less than 20% of tumor cells, and in fact, it can be seen on the DNA level, amount of DNA level, and you can see that we have in some cases, not few, but most several cases, very few amounts of DNA. So if we have very few amount of DNA, most of the time you will not be able to perform NGS. So we're going to talk about this in a few minutes. Another point, so I was talking about a few minutes ago, it's the fact that most of the samples are fixed in formalin because pathologists need this fixation to do their analysis. The problem is that the formalin induces a lot of things in the tissue. For example, it induces DNA and protein cross-link, okay, but most importantly, it induces the transformation of and the elimination of cytosine and the transformation of cytosine into a C2T, to thymine. So it induces, in fact, false mutation, and it can induce error in your interpretation. Here is just an example to illustrate what I was talking about. The idea is you can misinterpret the samples depending on the quality of the tissue. When the DNA is highly degraded, you have error in the DNA sequence, and so you're going to preferentially amplify this error, and at the end, you will not be able to differentiate if this error is an artifact of the DNA amplification or if it was present at the initial step, I mean, in the DNA, so in the patient. So it's not the case. You can see if you have a very good quality of the sample. If you have a good quality of the sample, you are sure that the abnormalities, molecular alterations that you're going to identify is really present in the tissue. So to avoid this problem, we have developed in our lab a specific NGS approach that take into account the poor quality of the samples that we can have in the laboratory, and we perform a comparative study. We conducted a separative study, and we demonstrated that this approach was very efficient to identify mutations that are not linked, not present because of an artifact. And here, just as a summary, you can see that using conventional NGS approach, we are not able to identify some mutation, but using our approach, we develop a very sensitive and efficient NGS assay. Also, an important message is to give today is the fact that these NGS techniques are completely depending of bioinformatic analysis. In fact, you cannot obtain good results if you don't have good bioinformatic processing. So we have also developed in our laboratory specific bioinformatic process, what we call pipeline. As you can see, you have several steps known as primary, secondary, and tertiary analysis, and ranging from output file of the sequencer, which are called FASTQ files, to annotated variant file that we call FCF. So we have developed a specific algorithm and a specific process that take into account the fact that we're working on FFPE samples. And in fact, at the beginning, we used external solution, commercial solutions, but we can find that these solutions are really not efficient, and that we are very confident in the result we get today using this homemade bioinformatic processing. So just to be more practical, here are presented the list of the genes that we check, that we look for in our laboratory. So we have different panel of genes. We have what we call the short solid tumor NGS panel. You can find here the most frequent mutation that are need for clinician to propose target therapies in oncology. So for example, you have EGFR, CAR, and so on. We also have a larger panel which do the same. I mean, it could identify these hotspots as well as MSI status, but we add other interesting genes, for example, PGFR, PIK3CA, TP53, TERT, or yes, FGFR1, and so on. So it's sometimes we do it because we need it. We also have another panel using capture techniques that I just explained you. So this panel is processed when we want to do and identify mutation in BCR1, BRCA1 or 2, for example, but also for other genes like Pol E, in endometrial tumors or other genes. We also perform RNA panel detection, and we use for this, we have developed with a society specific kit, which is called now the FusionPlex panel. And you can see that using this panel, we can identify mutation on ALK, ROS, RET, which are the most known fusion rearrangements that are not to be tested in lung cancer, for example. And we also developed recently a sarcoma panel. Finally, we developed what we call the shallow exome sequencing. So I do not have time to explain you, but maybe you know that in ovarian cancer now we need to score cancer for the HRD status to allow patients to be treated with olaparib. So we have developed a specific testing that is a concurrent testing to Myriad test, which is an American one. We do methylation on MGMT. This is for the neuro-oncology tumors, neurological tumors. We do TERT promoters mutation, and we also have another section of the lab which is involved in the germline mutation identification. And we do the classical, we perform this test to identify classical molecular alteration on Brackness genes and other genes that are involved in these familial tumors. Just to finish my talk, I will focus on and briefly discuss on liquid biopsy-based approaches. So it is important to note that tissue analysis that I just presented provide a significant representation of molecular profile in a tumor, but only at a specific moment of the oncogenesis. So we know now that under the treatment with target therapies, there is a therapeutic pressure, and you have the emergence of mutational profile that correspond to the resistant mutation, and that this resistant mutation are now targetable with specific therapy. So it's very important to detect this resistant alteration after the introduction of TKI, for example. So to do that, of course, you can rebiopsy patients, but it's much more practical to do it on circulating blood. So a lot of laboratories have developed assays to detect alterations and molecular alteration on blood, on the ctDNA, what we call the ctDNA, the cell-free DNA. So to do that, we have developed hotspot mutation identification using Streck tubes, which allows the conservation and the good conservation of the ctDNA in the blood, more than 24 hours. And we perform a specific detection of several mutations, which are right in here. KRAS mutations, the most frequent mutation, BRAF, EGFR sensitive mutation with Del19 and the other ones, EGFR resistance, and MET amplification. But we also develop, but it's more for research, we have also performed NGS on ctDNA. The advantage is that you, once again, you can test a large number of gene and hotspot regions. But the problem is that you need a high quantity of DNA, so you need to have a lot of samples for a patient, and that is quite expensive. So it's not possible to do it in a routine use, as a routine use. So finally, the prescription of targeted therapy is now widely recommended through implementation of molecular tests, such as few gene panel testing or whole exome sequencing, as well as for fusion detection. This test can be performed on tissue sample, on circulating tumors DNA, but in the future, it's highly sure that additional molecular targets will emerge to propose this molecule. We need to perform this kind of approaches and NGS approaches. NGS technology are also rapidly evolving, and now you can see that major sequencer, which was based on Illumina technologies, are not the only one solution that you can use. For example, Nanopore or Pacific Bioscience, that other company, wants to develop such devices that we could use eventually in our laboratories. So there is a big competition between groups. One other point important in the future is that the cost effectiveness of NGS sequencing is more and more used. And now it has been, for example, proposed that we could perform genomic testing from birth. And it's a project that is currently performed in United Kingdom, for example. But one limitation to the development of these NGS approaches is that the fact that even if the technical sequencing capacity is increasing, the ability for biologists to identify mutation is not increasing as well, and the number of interpreters is limited. So it's probable that in the future we will have to find physician or clinician or biologists that could help medical clinician in the interpretation of this data. And finally, I would say that the future probably will focus not on the identification of new molecular alteration, but more probably on functional tests. And we have an example today using on the HRD test and the prescription of PARP inhibitors in ovarian cancer. Yes, that's my last slide, just to show you that in research, it's an interesting things that are currently done. This research perform, in fact, what I just show you. I mean, the molecular complete identification of a tumor, a somatic identification of the tumor, but also you can have additional information on the genomic constitutional aspect of the patient. You can add information on so DNA, on RNA, and you can also have information on imaging, on other histological parameters. So the idea is to develop and to perform studies that combine all this information to identify the perfect biomarker or the biomarker or the panel for biomarker of the panel for parameters that can sensitively and specifically identify patient, not only at a very advanced stage of the disease, but also in the early step of the disease. So yes, thank you very much for the attention.
Thank you very much, Professor Solisol, for your enlightening and interesting presentation. It has certainly given us a deeper insight into the different molecular biomarkers in digestive carcinomas, and also the molecular process screening using NGS and the circulating tumor DNA also. So we will move now to the question and answer segment. I encourage all to participate. And Dr. Abdullah, as mentioned, you can pose your question in the chat box or by raising your virtual hand. Dr. Abdullah will help me in this process. And please, yes.
And thank you, Professor Solisol, for rich presentation. Thank you, Dr. Shuaib, as well. Just to add that the mic is open as well for all people who would like to ask any question.
I've just seen one question concerning epigenomic analysis. So in fact, I don't talk about this, but that's right that now we can study the exome, so the part of the DNA that is informative and that is coding for the protein, but we can also study epigenomic. We can study intronic section of the DNA and epigenomic data. So the problem is that in a currently point of view, we do it only to determine the methylation of the promoter of TERT, for example, or MLH1 in neurological diseases, cancer disease. And if we want to study the epigenetical aspect of the DNA, we need to perform whole genome sequencing. And as I explained you, today we are not able to do it in our laboratories. We can do it in specific platforms, Sequoia and Orasec. We have in France 2 mega platforms that do it, but they do it not on FFP samples if they are not allowed, and they can't do it on FFP samples. They do it on frozen samples. So you see, you have a limited number of facts and parameters that explain why epigenomic aspect of the disease is not largely studied using NGS approaches.
Thank you. The question came from Ragad Busaidi. Yeah.
So if I can ask also, Prof, in the context of digestive carcinoma and the different types of GI tumors, and you presented different panels of genes, do you recommend using one comprehensive panel with MSI, TMB to be run for all advanced cases, or depend on the type of GI, you will select a particular panel?
So that's a very interesting question. In fact, you know, as I explained you, we have a large number of patients that need to be investigated for this molecular alteration detection. So in a routine point of view, it's quite difficult for us to perform a very large comprehensive panel involving effectively more than 200 or 300 of genes, MSI, TMB. I don't talk about the TMB, but TMB could be also interesting effectively to determine patients that could be treated with immunotherapies. So once again, in a routine point of view, it's not possible to do it here. I don't say that it's not interesting. I would say that sometimes it is interesting, but more probably for patients that could be involved in clinical trials. For classical treatment, as I explained you, level 1 ESMO recommendation say that we just need to know the the mutation status of KRAS, NRAS, BRAF, and other limited number of alterations. So this comprehensive panel could be interesting for institutions that can involve patients in clinical trials, and sometimes to know the TME, for example. That's my point of view. But in the current use of this molecular alteration, I think that hotspots are sufficient. And another point, very important, is the cost. Of course, our cost to have a minimal set of molecular alteration is around $1,000, $100. But if we want to do FMI, for example, it's much more expensive. So, so that's also a question of the cost of the study and the fund and the fund you can get with your institution.
Thank you. Since there is no question, I will ask another question.
Mm-hmm.
So, in case, as we know, MMR by immunohistochemistry and MSI by different techniques. There is a PCR, there is NGS, MSI. Now, let's say in scenarios where there is discrepancy between MMR by IHC and NGS MSI result, and the patient is being evaluated for immune checkpoint inhibitor treatment. So what do you suggest in this case? Which result, which method you will prefer, and to take a decision in the lab that MSI is positive or MMR is positive or deficient?
So here, what we do is, so we do immunohistochemistry as a screening test, because as you know, it's quite easy to perform. So we have this information. And we systematically do perform MSI using NGS. Why? Because as we check for KRAS and BRAF, it's the same NGS allows the identification of the MSI status. So for us, it's very easy to do. We do immunohistochemistry, it's very easy, rapid, and quite sensitive and informative. And we do NGS also. We do the same. I know that colleagues only do immunohistochemistry and FISH, and other one think that the NGS is less informative than FISH, for example, or less sensitive than FISH. So I would say that it really depends on what you used to do in your institution and what is available. If you have an NGS approach easy to perform and rapid, I would say, okay, do it. Because in our hands, the information is the same between the FISH and the NGS. I can see any difference. What is also interesting is for endometrial cancers, for example, as you know, sometimes the pentaflex or this the STR PCR testing is not optimal. You only have 5 STR. You focus on 5 STR. So for endometrial, for the MSI status in endometrial cancer, we, for example, prefer to do NGS because on our panel we have more than 10 polymorphism. We check more than 10 polymorphism, so much more informative fact. But once again, I would say it depends on your laboratories and what you have. I would say that the standard, the gold standard is to do immunohistochemistry and FISH. It's the gold standard. But here we do immunohistochemistry and NGS.
Thank you. Thank you. We have a question from Fabrizio Bonaro.
Hi, Fabrizio.
Hi, Jerome and Shaib. Congratulations for this excellent presentation. As usual, I have just a practical question. Which is the role of this molecular analysis for recurrence cancer during chemotherapy? So practically, could you propose a a liver met biopsy in case of not response to chemotherapy, and when? Do you understand my question?
Yes, I think I understand. So
yes,
first of all, I would say that most of these molecular testing are performed at the initial step of the management of the patient. So when the patient has a metastatic disease, you need to know if a patient can be treated with oral therapy or with chemotherapy. But if patients, for example, do not have sensitive molecular alteration, so you do chemotherapy. If you do chemotherapy, after a moment, you can also propose. I mean, if you do chemotherapy, it means that the patient probably do not have molecular alterations that are druggable using TKI, for example. So if you do chemotherapy, what would be interesting is you do chemotherapy because you prefer to reserve your TKI treatment for a second line. But then you will treat the patient with the right targeted therapy. You understand what I mean? So even if you don't have done it, first of all, you're going to do it in a second step. So you always need, in fact, if you want to do target therapy, you always need to have the companion test and to have the right molecular iteration. So I would say it's interesting to do NGS on patients that has been firstly treated with chemotherapy for the immunotherapy management. If we want to treat patients with immunotherapy, I don't know for liver cancer because it's not my specificity, but for other cancer, you can do these NGS approaches to determine if the patient could be treated with several anti-PD-1, for example. Do I answer correctly to the question?
yes.
I just need to also elaborate more on our practice in our new center. We are doing the MSI by IHC, immunohistochemistry, as a routine standard. And also we run next generation sequencing as a comprehensive panel, around 500 genes with MSI and tumor mutation burden. So we run it to get more information, because since we are also a research center, so running a comprehensive panel and getting more information on our cases will be also interested. So just to explain our current practice center.
I understand.
There is a question from Professor Mansour, who is the CEO of the center, and he's an oncologist. He's saying, what's the opinion of you, Professor, about commercial companies testing like Caris versus in-house testing with advocacy of depth of analysis and artificial intelligence and etc.
So what about commercial solutions? Okay. Once I would say that I prefer to know what I'm doing instead of asking to someone else to do it. I mean, most of time, what I appreciate a lot is to understand what I'm technically doing. When you use this commercial panel, of course, it's quite interesting. But the problem I would think is that you don't really understand or develop the assay, so you don't know the limit of the assay. That's what I wanted to explain you. For example, these commercial kits, it depends on the kit, of course, but these commercial kits can be practical, very interesting, and allow to do NGS. But we have seen in our lab that sometimes we were not able to amplify the DNA because these commercial kits are performed on and ask you to have a large number of tumoral cells, a large amount of DNA. But in practice, once again, we have small samples, small biopsy, and I prefer to know and to increase the level of sensitivity of my test rather than use a commercial test that will say not amplify and no answer possible. So that's the first point. And the second point, which is quite important, is, to my point of view, is the fact that when you use commercial kits, usually you also use commercial bioinformatic solutions. And once again, you don't really understand, it's like black boxes. You don't really understand how they perform their pipelines and if you're sure of the results. So my philosophy, my mind is to develop, if I can, of course, to develop the process and to implement the process, to add the new targeted molecular alteration I want to focus on, and to do it by myself. I understand the process, and yes, I can be more confident in my results. But once again, you need bioinformaticians, you need technicians, and so on.
My input regarding the commercial assay like CARIS, since they are doing like transcriptome, maybe in some cases like advanced metastatic or unknown primary site where we need any information. So running transcriptome, running whole exome or whole genome, maybe will give us a marker or biomarker in our case, because in our setup, we are running a comprehensive panel, only 500 genes, and we are running target number of fusion genes, will not cover everything. So having on the second hand, a commercial kit doing everything, I think will be interesting to have also. One point also will be maybe my last question regarding circulating tumor DNA. Did you experience any false positive results using circulating tumor DNA because of clonal hematobiosis or germline variant like TP53 contamination?
So can you, I understand the last part, but not the beginning of the question, sorry.
Using liquid biopsy, circulating tumor DNA, running it by next generation sequencing. Okay. And there is a possibility of getting a false positive result.
Yeah. Sure,
so
certainly.
Did you experience such results?
Yeah, we're ongoing doing this NGS approach based on ctDNA analysis. But you're right. In fact, we have a lot of parameters to evaluate heteroclonality, for example, as we explained, and other things. I would say that these kind of assays are very interesting, but I will reserve them for research only. And certainly, it could be interesting to compare results that you can get in your laboratory and ours. Using these NGS ctDNA approaches, and in fact, you can read a lot of publication on this, and people are able to do it technically. That's sure, but in a clinical point of view, it will be interesting to compare the results that you can obtain on tissue with ctDNA, for example, to be sure that you not miss a lot of alteration and you not have, as you explained, false positive cases. And so this kind of development, as that was I explained at the end of my talk, need a lot of implementation and evaluation before to do it in routine clinical setting. So yes, certainly it would be interesting to develop it. I think in such cases, international or inter-laboratory studies could be very helpful, and that's a very interesting point. But for routine, I will be very uncertain. and I prefer to reserve it once again for research. Actually, I mean right now.
Another question.
I don't know. Yeah, sorry.
Just it's another surgeon question. How frequent do we see like mutations or mutation variation between the primary and the metastasis, or for example, the primary and later on recurrence of the disease? How frequent that we see it in GI cancers?
And so yes, it's quite known that effectively there is an evolution of the clonality during the cancer process and the carcinogenesis. So in fact, most of the time, all the mutation or all the molecular alteration are present at the initial step of the disease, but they are present. Some of them are present at a very low amount. So you're not able, using classical conventional PCR techniques, you're not able to detect them. But after, it's like with antibiotics. When you select some clones, you're going to see the emergence of other clones that were so at the beginning very few, but after several lines of treatment, you will see this clone at high level. For example, in our laboratory, we study in lung cancer, and we have identified using ddPCR, the high sensitive technique. We identify clone that was present, resistant clone that was already present at the beginning of the disease before the introduction of TKI. Before the introduction, but after the treatment, of course, you have the emergence of this clone. So, to my point of view, this heteroclonality is present, and explain most of the time why patient resists, and most of the time why they're going to resist rapidly. So it's always interesting to know that if you study the primary site of the tumor or a metastasis, for example, because you can obtain different results. And sometimes we have both samples and we have different results.
Thank you, bro. Thank you.
Okay.
I don't know if there's any other questions.
So thank you very much.
Thank you, Dr. Shaib. We can conclude.
It was a pleasure.
Thank you. Thank you.
There's another question, sorry, last question from Dr. Augustine, who's an oncologist, GI oncologist. Any comments about minimal residual disease / circulating DNA for stage 2 colon cancer in order to support the decision of adjuvant chemotherapy? If it has been standard practice for you.
Alors, donc today we perform ctDNA and we have administration authorization to do it only in lung cancer, not in colorectal cancer, because the equivalent of the FDA for us is given in lung cancer, but not in colorectal cancer. So for practical point of view, it's not performed, but that's right that in stage 2, if you identify a specific alteration, you can modify the chemotherapy treatment. But here we do not do it in routine. We reserve ctDNA determination, molecular alteration determination only for lung cancer, in a practical point of view.
Thank you, Prof.
So we're testing most of time. We're doing most of time ddPCR using biorad devices, which is very, very efficient and very sensitive. But you know, it's hotspot mutations that you detect. So, for example, for lung cancer, what is interesting is to identify the resistant mutation alteration mutations, T790 and M, And so we do this ddPCR to identify this mutation using ctDNA.
Thank you, Prof. Thank you very much. Dr. Shoaib.
Yes, so I think no more questions. صح Dr. Abdullah?
Yeah, I guess we end here.
Yeah. So thank you very much, Professor, for enlightening us on this topic and all for this interesting presentation and discussion. We really enjoyed it and hope we can host you again in our future webinars and meetings. And thank you to everyone for your time and attendance. Thank you, Abdullah, Dr. Abdullah, for this interesting opportunity.
Thank you very much for your invitation. Once again, thank you to all of you, to Fabrizio, and hope we can maybe do things in the future together.
Sure.
Thank you. Have a good day.
Pleasure.